Okay, our next speaker, Dr. Christina Fanola, is a cardiologist and vascular medicine specialist at University of Minnesota Heart Health Care. Dr. Fanola received both her bachelor's and medical degrees at George Washington University in Washington, D.C. She completed her internal medicine residency and vascular medicine fellowship at Boston University. She also received her Master's of Science in Epidemiology at Boston University School of Public Health. She went on to complete her fellowship in cardiology at Boston University. Dr. Fanola is board certified in internal medicine, vascular medicine, and vascular ultrasound. She has an interest in the management of complex aortic and venous diseases and the use of ultrasound in cardiac and vascular critical care. Please welcome Dr. Christina Fanola.
Well, thank you very much. Can everyone hear me okay? Is the microphone close enough here? Okay. So it's such an honor to be invited to this and to see several of my patients right now in the audience. I have a little bit of a unique spin on aortic disease. I'm kind of the investigator, after a dissection, after someone is diagnosed. I take about 10 steps back and say, why? Why is this happening to you? And I look at it, in kind of a precision medicine-based approach to aortic disease. So I'll go through a little bit about how I run my practice, and hopefully you'll take some things home from this today. I just have a few disclosures. I am on the 2022 American Heart Association and American College of Cardiology Aortic Guidelines Writing Committee. We are in the middle of publishing a new document, which will be out in about 6 months. Unfortunately, it's embargoed. I'm not allowed to share our updated guidelines, but I will happily share it with all of you when it's published. So I'm going to have to stand this way a little bit. Okay. So I like to go through the causes here. There's a lot of causes of an aortic aneurysm. So 80, 90-year-old with hypertension, potentially it's degenerative. I do a inflammatory aortitis clinic as well, so these are more rare large vessel vasculitis type situations, Takayasu's or giant cell arteritis. There are infections that cause aneurysms like tuberculosis and syphilis. Traumatic and motor vehicle accidents can enlarge the aorta. And I also see a lot of athletes in my clinic. We can see mild dilation over time in the endurance athletes. I do focus mostly on genetic in my clinic, and so these include syndromic, like Marfan syndrome, Loey, Dietz, and Ehlers-Danlos. I look at familial types, Turner's syndrome, and then the bicuspid aortopathies. So the aorta has a lot of different parts to it, especially the root that we look at. I like to look at the anatomy and imaging, what part of the aorta is actually involved, and can we actually tell the etiology or the cause of the aneurysm based on just looking at these different components. And aortic enlargement is not just one part of the aorta. There's all these different unique areas that we look at in imaging, and we decide maybe this is cluing us into why it's dilated. So when you see an echocardiogram report, you actually see these 4 things listed on your report. There's always a measurement for these 4 components. And again, each one kind of tells a story about what's going on with the aorta and the aorta root. I do a lot of echocardiography in my clinic, and so a lot of you like to look at your echoes as you're getting them scanned. This is a really great view and how we look at it in the echo lab, and we measure it. Unfortunately, it's 2-dimensional, so you can see there's probably a lot of artifact with an echocardiogram in measuring. That's why a lot of these we use as screening, and then if it's abnormal, we like to follow up with 3-dimensional imaging. We can look at the arch by echo. So after the root and the proximal or the first part of the tubular part, we can go march down the arch with echo and actually look at the part where it starts to descend above the diaphragm. We look at the aortic valve, and so it's really hard to see. It looks like a little alien there. I'm sure it's hard to decipher without video, but we look at the heartbeat through the aortic valve. We can tell if it's bicuspid or not, usually by transthoracic echo. There are some caveats to it, of course. And then we look at the abdominal. They've ever stuck, with the probe under the ribs, we can actually look at the abdominal aorta and get a sense of how flow is getting to that abdominal part and if that's also enlarged as well. So it's really confusing. What's dilated, what's not? As an echocardiographer, this is from the American Society of Echocardiography, their guidelines. So I take an age plus a body surface area approach, and we are correcting these guidelines a little bit upcoming this year. But for the most part, you take your age, you take your height, your body surface area, and you have what's normal for you in these boxes. And then we can actually see how dilated or how not dilated is your aorta based on these groupings right here. So, and we do that using standard deviations outside of this norm. Some of you have probably heard about a Z-score. We use this in the younger population as people are starting to grow and they're still in their early ages and maybe their height's not at the maximum height that they're going to be as an adult. A Z-score can be helpful and account for that age. And so we actually have a Z-score interpretation online. There's calculators. So a Z-score is helpful when I say I have a 20-year-old. I know they're probably still going to grow for the next decade. We can compare Z-score to Z-score over time, and that can be useful. So I'm going to march through a couple genetic syndromes. This is really to gain awareness. What are the syndromes out there? What are the associated findings? If you do have an aortic aneurysm, what else can actually happen with these aneurysms? So we think about the aorta and the aortic wall layers, 3 layers. A lot of the genetic syndromes or hereditary types come from breakdown of smooth muscle cells, your elastin and your collagen. All the genes that that synthesize collagen tend to be creating this disarray of that layer, and that can cause the aneurysm. So going through Marfan syndrome, so this is most common connective tissue disorder that we know. It's autosomal dominant, which I'm going to talk about a little bit. That means 50% in your offspring. So if you have a carrier of a gene, that gene is going to be carried into about 50% of the next generation, so on and so forth. And so it's a mutation where you have elastic fibers that can be fragmented and causing some altered matrix of the aortic wall. Here's just imaging clues that we look at. We have actual criteria, major and minor, for Marfan syndrome. So again, I look at the echo and I look at the various parts of the aorta and the mitral valve. It can affect the pulmonary artery, and we can piece together the likelihood of Marfans based on imaging. And here's just an example. You get a really dilated root near the aortic valve in Marfans. You can get a dilated pulmonary artery, and then you can get mitral valve prolapse. So you always want to look at the mitral valve when you have a diagnosis of an aneurysm. So patients have, they're tall, elongated arm spans, dental crowding, high arch palate, joint laxity, chest deformities, lens dislocation's a big thing. So I go through all of this in review of systems. And there's something just called Ghent criteria for Marfan syndrome. It takes into account the phenotypic features and also genetics and imaging. Loey-Dietz syndrome is also a genetic syndrome that causes aortic dilation, and there's a lot of different genes for this, and we have some 6 subtypes that we can test for. With Loey-Dietz, there's bifid uvula, which is a uvula in the back of the throat, split in half, a high arched palate, eyes wide, set apart. The problem here is there is vascular fragility in Loey-Dietz. You may not actually have an aortic dilation before getting an aortic dissection. So this is really important diagnosis to pick up front. There can be a root aneurysm like Marfan's, but 53% do not have the root involved. So it can affect other vessels, coronaries, the head, neck, pulmonary, and there can be other associated structural heart defects, including bicuspid valve as well. Ehlers-Danlos syndrome, this is a connective tissue disorder characterized by abnormalities in the skin, visceral organs, and blood vessels. Can affect really any blood vessel in the body. Again, a collagen synthesis gene mutation. Up to 25 can have aortic aneurysm disease. Age can be, I pick up Ehlers-Danlos as early as 20. I've had a 75-year-old that I've diagnosed. A lot of them have hypermobile joints, classic type especially. Vascular type does not have to have hypermobile joints, however. So, and this is the more rare type, less than 5% of the cases. And you can see how many different types of Ehlers-Danlos there are. This is from 2017. And with vascular EDS, there's a specific gene that's pretty sensitive for it, the COL3A1 gene that we can test for, and that's specific to the vascular type. And we can diagnose patients like this. We do sort of a phenotypic assessment and see, if they fit this criteria. We do, of course, want to know this as well. There is vascular fragility associated with vascular Ehlers-Danlos. We'd like to know that preoperatively going into something where we're going to do catheter-based procedures. We really like to nail down this diagnosis and make the right preventive measures for these patients. And bicuspid aortopathy and coarctation of the aorta. So bicuspid is a common prevalence pretty much. 50% have a root or ascending aortic dilation, and less so coarctation, which is a pinching of the descending aorta. So the dissection risk is increased compared to a normal tricuspid valve, and I'll go into that. And sometimes coronary anomalies can exist. So you see on the left what bicuspid valve looks like, normal versus bicuspid. There's a fusion of two of those leaves, and just it opens up and causes eccentric flow. Coarctation on the right, it's a pinching right after that arch. You can have various types. There's 4 subtypes there. With bicuspid aortopathy, so you can see on the left, basically the bulging can be very early on after the valve, or it can be later closer to the arch, and I'll go into why that is. And you also get sort of a destructive smooth muscle cell loss and also loss of collagen as well. I show all my patients this picture. I think this is so telling with bicuspid aortic valve, why some people get dilated and some people do not. This is 4-dimensional MR angiogram flow. I think this is an extremely important article that came out. The first one on the left is normal. You see all the blood flow is in the red. That's where all your blood flow in a heartbeat is pumping out. It's right in the middle of the vessel. It's not banging against the walls. The second one is a right and left fusion bicuspid valve. You can see the way that the jet of blood flow is going. It's hammering on that one area and swirling around. Over time, that's going to dilate that aorta right there. But the third one, this is a right and non-fusion. You can see that, yes, there's flow that's on the side of the wall, but it's not actually swirling around and causing as much dilation. So with bicuspid valve, you might not get a really large aneurysm, but the risk of dissection might still be there. So it's really important to look at the type of fusion, look at 3-dimensional flow, and really understand the dynamics of these patients' blood flow. And bicuspid valve, like I said, is kind of easy to pick up on echo if you get a good image. We can do all the survey of the aorta there. Coarctation, we usually do CT angiogram imaging or MR angiogram. We look at the pinching of the downflow aorta there. So there's a lot of other associations with congenital heart disease. So sometimes if I pick this up, I will also do a full cardiac MRI to look for other congenital valve or septal defects. You can see coarctation on the aorta. It's not extremely sensitive, but we can get a clue, and then we would follow it up with CT or MRI. And clinical features of coarctation. So if you have a bicuspid valve, you should always be screened for coarctation, especially if you have long-standing hypertension. If you have any signs of poor blood flow, basically it's pinching off blood flow down to the rest of the body. So you can get pain in the body, you can get pain in the abdomen or down to the hips or the legs even. You can get diminished pulses, so it's important to screen for that. Coarctations can be easy to repair. We have both endovascular and surgical approaches, and there's ways to measure that gradient through a catheter to decide if it's necessary to repair or not. And the last group that I'll talk about is just familial types. So I see a lot of these. So again, autosomal dominant. Familial types we see a lot in every generation. 50% can carry a mutation. So the ones that I see that were most described in literature are ACTA2 mutations, the TGF-BR2, and MYH11. But we're seeing a lot of new genes come out that we still think are familial types that we're starting to write up about. So suspect familial types if you're young, there's sudden cardiac death in the family, unexplained heart attacks with no autopsy, and then multiple aneurysms in family members. And then you don't fit necessarily other features of the syndromes. So this is a case study, for example, that looked at these 3 familial type mutations, case series that was published. So one patient had the MYH11, it had a dissection at 4.5, the TGF1, multiple aortic dissections documented less than 5, and then the ACTA2 less than 5. So why is this important? Well, our next guideline's coming out. You know, we're no longer getting to a absolute diameter of 5 to 5.5 for everybody. We need to take into account family and genetics, and how does that actually help our management. Here's just a summary of imaging guidelines for the various syndromes. Everyone usually gets 3D imaging. Most people, once they have an aneurysm, we do annual screening. Usually after the first diagnosis, I like to do a 6-month scan just to document growth. And then after repair, of course, usually it eventually goes to 6 months to annual screening as well, or surveillance. So screening first-degree relatives, bicuspid aortic valve, premature onset of thoracic aortic disease with minimal risk factors, or any type of familial form of thoracic aortic aneurysm. So I try to make good recommendations on who to get screened and at what decade should they start screening. So we offer a panel of gene sequencing. There's about 35 aortic genes that we have from Ambry Genetics. Insurance covers most of it, and the company actually picks up a lot of it as well. So it's a low out-of-pocket cost for patients. It's not helpful in everyone. We don't do it for everyone, but it can be helpful in large families with a lot of kids and grandkids. If we discover one of these mutant genes on the right, then first-degree relatives can undergo screening for that exact gene and find out who needs to have sort of that long-term surveillance imaging. A lot of my patients have a variant of undetermined significance. Now, what is that? That's it's associated with these mutant genes, but may not be the exact location of the original gene. I still think it means something. Sometimes family members will test for that variant, and it can help in certain circumstances. And then surgical guidance, again, this is going to change soon, but Marfan syndrome, usually repair at 5 centimeters, or if there's rapid growth or family history of a lot of dissections. Vascular EDS is really independent, case-by-case basis because of their higher vascular fragility during surgery. Loey's Dietz, actually lower diameter. They tend to dissect earlier, so we say even 4 to 4.5. Familial types are really based case-by-case basis for sure. And then bicuspid, we are recommending, if there's valve disease, 4.5. If there's no valvular disease with it, no regurgitation or stenosis, then usually 5 is our cutoff to start thinking about elective repair. And degenerative old person who is low risk, potentially 5.5, or if there's growth. And then best practice for my recommendations, figure out the aortopathy first, and then you figure out the surgical plan. So this is Fanola's Guide to Medical Therapy in Aortic Disease. This is very general. So antihypertensives, if I can squeeze losartan on people, I will, and beta blocker, that really helps that anti-impulse therapy that bangs on the aorta. Antiplatelet agents, if there's concomitant plaques or cholesterol in any of the vasculature, or if there's peripheral artery disease, coronary disease, then we consider an antiplatelet agent. Cholesterol management, if there's high cholesterol, statins might. There's some data to suggest that statins could reduce growth due to its anti-inflammatory properties. A good diet, Mediterranean diet, and for vasculitis patients, we do steroids and kind of the big gun medications to prevent inflammatory growth. So exercise and lifting guidance, avoiding Valsalva. Valsalva just means you're really bearing down, like you're having a bowel movement, that straining of where you're contracting your abdominal muscles, that shoots up your central blood pressure. Some people who are athletes and my really active patients, I'll actually bring them into my stress lab who have either post-op dissection or an aneurysm that's mild. I won't push them to the limit, but I'll say, do what you normally do for your favorite exercise. We'll see what your blood pressure's doing. If it's skyrocketing, we know we have to be more aggressive and actually give even temporary blood pressure meds during their exercise. Stress management's really important, pre and post-operative, yoga, meditation. It is okay to exercise, moderate intensity, avoiding high intensity interval training. Post-surgical, we try to get everybody into cardiac rehab programs. They've been doing an amazing job for our aortic patients. So again, the document will come out that will go into specifics about all of these categories. And I want to just give special thanks to my patients. This is a unique disease. Again, awareness is critical. Since I've started my clinic, I now inherit family members and children and nephews and cousins. It's really meaningful to just prevent these events from happening by getting them established early into clinic. And I will apologize that I have to leave. So who knows Jessie Diggins from the Olympics? Anybody? I am skiing the American Birkebeiner tomorrow. It's 50 kilometers. I'm as crazy as her, so I will be heading off to do that today. So that's my little special interest on the side. But it was a pleasure to be here, and thank you. And here's my email. Reach out to me anytime with questions, concerns. I'm happy to talk to any of you. So thank you very much.